is Andy Lane. I'm a physician and a scientist at the Dana-Farber Cancer Institute and Harvard Medical School in Boston, Massachusetts. BPDCN is blastic plasmacytoid dendritic cell neoplasm, and it is an aggressive malignancy of blood cells thought to result from transformation of a dendritic cell precursor. In the past, it had several other names like NK blastic lymphoma or CD4, CD56 hematodermic neoplasm, but in 2008 it was given the name BPDCN on the basis of understanding a bit more about the biology of the disease. So patients with BPDCN can present in two ways. About half of the patients present with skin lesions, and this can look like a rash or a tumor. It can sometimes be in multiple areas of the body or just a single spot. The other half of the patients present more like a traditional, if you will, patient with a leukemia or a lymphoma would, where they would have symptoms related to the tumor leukemia cells in their bone marrow or their lymph nodes. So low blood counts, fatigue, bruisability, bleeding, those sorts of things. So it can be one of those two different ways. So the first part is really making the correct diagnosis, because we think that the therapies we choose will be dependent on that. But the short answer is that we try to give intensive induction type chemotherapy like we would normally give to a patient with acute leukemia, like an AML or an ALL, and then try to take the patient to a stem cell transplant, most often an allogeneic stem cell transplant. That was what we would do for a patient who is younger, able to tolerate those kinds of therapies. For an older patient, we would also try to think about getting them to a transplant, maybe a reduced intensity transplant, by using some kind of reduced intensity chemotherapy first. I think there are two main challenges. The first one is making an accurate diagnosis, because both the dermatologist, for example, if they're doing a skin biopsy, or the hematologist doing a bone marrow biopsy, and then the pathologist have to have BPDCN on their mind to make the correct diagnosis, because it requires a special set of stains to be done on the pathology. And then once the diagnosis of BPDCN is made, separating it from an AML or a T-cell lymphoma, those are the two things that might be misdiagnosed. Once the BPDCN diagnosis is made, the challenge is really giving the patients a high intensity of therapy to get them into remission so that we could maybe get them to a transplant without suffering the toxicities of those therapies. And that's really also made more difficult by the fact that this is a disease of elderly folks. It does happen in kids, but the average age of a patient with BPDCN is probably the upper 60s. And so we need therapies that are tolerable by that patient population, and that can sometimes be a challenge. And the final challenge is that our therapies that we currently have, while there are some decent response rate in some patients, meaning their disease responds, the responses are often very short and often not long enough for us to get the patient to the next step, like a transplant. And when the disease relapses after the initial chemotherapy, it is often very aggressive and very difficult to treat. So SL401 is a new agent that is a recombinant protein fusion of IL-3 to diphtheria toxin. And so it's delivering diphtheria toxin to the BPDCN cells that express very high levels of the IL-3 receptor. And this drug, the main advantage is that it has a very high response rate, and it is very well tolerated. And those two things together are making it, an optimal new option for the patients, because we're able to give it to patients who might not have been able to get intensive induction chemotherapy, either because of their age or other medical comorbidities.